I'm Josh Schreiber. I'm actually the local Utah chapter president. My signature still shows UAHU, the Utah Association of Health Underwriters, while we transition into the new name, the NABIP Utah. And Doug had reached out to me, kind of letting me know that you guys are looking for what today's CE is, specifically something in regards to Medicare compliance. And both locally and in the national chapter, we do this very well. And I reached out to Mike, and actually we ran into each other in DC as a lobbying organization. We're both doing things locally and then nationally, and we were doing some lobbying back in DC at the end of February. But I've had Mike do these for us before as well. And Doug wanted you guys to know what the national and what the local association does that you guys might benefit from. One of these is getting up to date on Medicare compliance. And then, of course, the association does this for all kinds of lines of insurance. But Mike does this very well. I've had him out here last year. He did a couple of face-to-face CEs as we do a Medicare summit. We're planning on doing that again this year, probably in September. And I wanted to let you guys know of other things that we do that you can participate in, both as members and non-members. For example, we do monthly Cs as well. And in April, next month, the middle of April, we're going to have 3 hours of ethics. We're going to have our largest event of the year in May. It's called our Sales Congress. And I'm just going to post a link to that site where you guys can get some more information and register if you wanted to. There's a golfing event on May 16th, and then the actual Sales Congress where we've got Thurl Bailey coming out as our keynote speaker. And we're going to offer 5 CEs on that day as well. We'd love to have you guys there. And then at our monthly Cs that we're primarily doing them face-to-face, we're beginning to get into the process of allowing them to be Zoom for those folks that aren't too close to Salt Lake that can't travel here, to where we can do these virtually as well, as you guys do that primarily this way already. We just do them face-to-face, but we want to be able to offer them in 2 different formats. So there's a lot to be had from the association, and I want you guys to see from what Mike's doing. This is something that y'all have access to as well. Again, as members and non-members, we'd love to have you join us for future events. And so with that, Mike, I'll go ahead and turn the time back over to you, and then Doug and Stonehill, thanks for inviting us out today.
Well, thanks, Josh. Appreciate that.
Yep. Thank you all. And I'm assuming you can see my screen and that the volume is okay.
Yes.
Okay, awesome. Then let's get started. We're going to talk this morning about some basic things in Medicare. I'll throw out some statistical data just to kind of give you an idea of who's doing what as far as Medicare beneficiaries, if they're enrolled in a Medicare Advantage plan or Medicare Supplement plan. We'll talk a little bit about the marketing rules. Some of these have just recently been passed. Others are proposed. Of course, I want to provide you all with some legislative updates. I think everyone here on this phone call understands that legislation drives a lot of what we do, whether that's in the group market or under age 65 markets. But we certainly have to pay attention to legislation and also regulation. And then I want to share with you all some of the things that NABIP is doing to help support Medicare agents. We also have a certification course, some of the things that Josh just mentioned about study groups and local meetings, Medicare summits, and then, of course, the Medicare Advisory Group, which I've had the privilege of being chairman for the past 4 years. My term ends in June, but that has been quite an eye-opening experience to see things at a very high level in DC and really try to help shape what it is that we do and protect the agent in their role in the distribution of insurance in the process. So let's go ahead and dive right on in here. Some of the statistical data, and I understand that some of you may be in the Medicare business and some of you just might not be active, but are quite aware of all the different activity that happens in Medicare. And as you can see from the screen, the statistical data where there are well over 10,000 baby boomers turning 65. It's actually probably a little over 11,000 people per day right now. As you can see, that's pretty strong through almost through the end of this decade. And so for those of you that might be on the sidelines, it's not too late to join the party. If you want to help people with Medicare, I think you'll find that it's a very easy business, and also that the people you assist are very grateful for helping you, and they are absolutely eager to go and share your information. It's a very weird thing. Medicare psychological, when people turn 65 or approach 65, they get hit up by everybody, and it's very confusing. And even very smart people get very confused about this. And if you can just boil down how to handle the ABCs of Medicare, not only do you earn a client, but they're so relieved that you've taken this burden from them that they go and brag about you to their friends. So there's a lot of business to be had. Let me just also chunk in something here. I read this statistic the other day that was somewhat alarming, that in the year 2031, the oldest baby boomers begin to turn age 85. Let that one sink in, and think in terms of a long-term care claim. That's a whole nother topic, but just know that this is a huge demographic that has driven many things, from Barbie dolls to elementary schools, colleges, now, of course, Medicare. So if you're not involved, there's still plenty of room for you. Statistically, let's look at some of the things. Medicare Advantage, which is Part C, almost half of the Medicare beneficiaries are enrolled in a Medicare Advantage plan. And this has been a trend that's been strong and growing for many years. We had an 8% increase from 2021. I haven't seen the most recent final statistics for 2023. My guess is it's probably knocking on the door of about 50% of people are enrolled in a Medicare Advantage plan. And that's quite a lot. There's around 63 million people that are in Medicare, period. Some of them are on group Medicare Advantage plans. Others may be in a retiree plan. They might have worked for a school district or a city or a large employer. Quite a few of them still have original Medicare, which is Part A and B, with a Medicare supplement and a prescription drug plan. And just 10 years ago, just over 1/4 of the beneficiaries were in a Medicare Advantage plan. So as you can see here, from a trend perspective, Medicare Advantage has grown significantly. And we're very involved, of course, in the enrollment of Medicare and trying to understand why. And we have figured out there's a lot of reasons, but the bottom line is a Medicare Advantage plan looks and feels a whole lot like the type of group health plan a person may have had most of their life. HMO, PPO, in or out of network, co-pays, co-insurance, cost sharing. But Medicare Advantage plans also go a little further, and they may involve things like dental benefits, for example. So it's been very popular. About 2/3 of the people who are in a Medicare Advantage plan are enrolled through an individual, most likely someone like you on this phone call. The other 1/3 are probably a group Medicare Advantage plan. And again, that would be most likely a retiree plan. So if you have any companies you work with that offer retiree benefits, you may have seen some of the things changing in this area, where there may have been 5 or 6 options. Now, many of these retiree plans are just cutting it down to one Medicare Advantage plan if they're not cutting out the retiree benefits entirely. And that's a thing I want you to take away. There's around 10 to 12 million people who still get their retiree benefits through a previous employer. And a lot of those employers are really struggling to pay those costs for the retirees. And we see a lot of cancellations in this area where people are transitioning over to an individual Medicare plan of some type. Here we are, about 18% of these plans are available through an employer or a union. And then about 16% of this population, 16% are in a special needs plan. That might be someone who's also eligible for Medicaid, or perhaps they are in a nursing home and they may have what's called an institutional special needs plan. Now, this world is dominated by several companies, some of which, United Healthcare, they're the largest at 7.9 million. Humana has about 5 million, and they had a really great growth year over the last 6 months. The Blues plans collectively have about 4 million of this population. And then who is CVS Health? I know that might be a rhetorical question, but think in terms of Aetna. Aetna is now owned by CVS, so they have quite a large book. But that does not mean that the world is all about Medicare Advantage. We also see a whole lot of activity with Medicare supplement plans. And as you can see here, Medicare supplement plans have also grown in overall premium, measured in the billions here in this graph. So a lot of people will ask me, well, do you think Medicare supplement has a future? And I say, yes, I do. And I would also kind of throw that back to them and say, if you went to your favorite ice cream shop, do you think that they're just going to serve vanilla for the rest of your life? Probably not. So choice is important to people. And when you're able to give someone a fair and balanced option of either a Medicare supplement or a Medicare Advantage plan and try to help them understand what's most suitable, that's key to helping a person. The suitability aspect of this, which of course goes hand in glove with compliance as well. Some of the trends we see with Medicare Advantage is that CMS, the Centers for Medicare and Medicaid Services, has really increased the funding quite a lot over the last decade. That also has fueled some of the growth and the trends we just discussed. But going into the year of 2023, CMS increased the funding 8%. And you have to stop and ask yourself, why? You know, you may have heard in the news that some of these Medicare Advantage plans are overfunded, or maybe that they are cutting back services and denying medically necessary services. No, not necessarily. I will tell you the truth of the matter is a Medicare Advantage plan is very different from original Medicare. MAPD, Medicare Advantage Plan with Drugs, operates under a premise of an ounce of prevention is worth what? A pound of cure. And so you'll find that with a Medicare Advantage plan, a lot of these products will have a very robust package of $0 copay for preventive care. They truly want you to use your plan, whether that's for dental benefits or age-appropriate male exams or women, mammograms, whatever it may be. And if you look at the total cost of a Medicare Advantage compared with original Medicare, the argument is very strong that a Medicare Advantage plan is actually a more efficient way. And I think part of that is because it's managed by private health insurance companies that focus on trying to keep people from getting sick. So in other words, let's find that heart attack before it happens and help coach them on things like how to eat better, or perhaps be more proactive about getting their medications refilled. But there's a lot of activity in this area that we could discuss. They also offer things like over-the-counter benefits. You may get $50 a quarter. You can pull up a website, and anything that you might buy in the drugstore, an over-the-counter benefit, you can order online and have it shipped right to your door. We've seen a lot of growth in what's called a flex card, which is a debit card that's been used for things like paying utility bills or providing light household cleaning, or maybe buying fresh groceries. And if you think in terms of people who may not have a car or can't drive, or perhaps they're low income and they're not used to taking very good care of themselves, they can't get to the doctor. Well, we can help them by either bringing home health care to them or even providing transportation to and from a doctor visit. And in some cases, many of these plans will have dental, vision, and hearing. The reason for that, they want you to get your teeth cleaned. Oral health is also in direct relation to overall body health. If you've ever had a vision benefit, you'll probably understand that an optometrist can discover whether you may have a trend towards diabetes or even hypertension. And hearing benefits also very important. People who can't hear very well may not participate in conversations as often. And when they don't exercise their mind, then what happens? Dementia creeps in. So all these things fit together in a proactive manner to provide wellness. And of course, who could forget wellness without some fitness benefits? So they will throw in gym memberships and encourage people maybe to go to water aerobics classes, or just do anything besides sit on the couch in a dark house, be depressed and sick. And then when you have a heart problem, it's really heartburn, not a heart attack. What do? They punch 911 and here comes the ambulance. Medicare Advantage plans do better of managing people's care. So let me change gears now and switch over to some of the marketing rules. And some of these are newly proposed rules that will be impacting us this year, and others are just recently implemented, like the call recordings that you may have heard. And of course, we've been heavily involved with trying to shape this legislation and react, unfortunately, to some onerous regulation. But again, legislation drives a lot of what we do. So that said, last year we just implemented call recordings and other things. And just as soon as we were getting used to that, CMS put out an entirely new set of proposed Medicare marketing rules. And if you're sitting on the sidelines of Medicare thinking, well, gosh, I don't want to deal with all that stuff, let me just say, it's not as bad as it seems. And as long as you follow these guidelines, it's not difficult at all to write Medicare business. The SOA that you see on the screen, that's referred to as a scope of appointment. And used to be, we have a scope that if somebody comes into my office today and sits down and says, I need to get a Medicare plan, well, I'd have to pull out a scope of appointment and have them check off the boxes that allow me to talk about certain health and or drug plans. What CMS is proposing is that scope of appointment be completed 48 hours in advance of the actual Medicare discussion. So this could be a big challenge because some people don't have 48 hours. They may need to do something today. Today's the last day of the month, right? And they need an April 1st effective date. So how will that 48-hour rule impact that beneficiary? It may have to push them into a May effective date. What could happen without health and drug coverage during the month of April if that's the case? So we feel like this is probably a very onerous thing, and we really are fighting against this. There's also a proposed 12-hour cool-off.
Mike, can I ask you a question?
Sure.
On the 48-hour, so when the 48-hour rule was in effect several years ago, back during the Obama administration, they had contingencies. So if someone walked in and it was the last day, you could have them sign a scope, and because it was the last day, there wasn't, you didn't have to have the 48, and you just had to be able to justify it. I'm understanding now that this new 48-hour rule is going to be even more stringent than it was under the Obama administration. Is that what you're saying?
Yes, I am. And I feel like a lot of this stems from the call centers. And let me just say up front that I know most everyone on this call might have used a call center at some point to generate leads, but you are not a call center by trade or by nature. And a lot of the call centers that you see advertised on 1-800 Joe Namath commercials, if you know what I mean, these folks watching TV will just pick up the phone and call that 800 number. And oftentimes they're convinced that they need to get into that plan that has transportation benefits or dental benefits. And these call center reps, which oftentimes are people who have not had 10, 20, 30 years of Medicare experience or even been in the insurance business, they will actually switch them over to a plan that might not be as suitable. And because of that, there was a significant increase in complaints to Medicare going from 2021 to 2022. That kind of kicked off those call recording requirements. And this SOA 48-hour rule ties in that what we're trying to do is prevent that type of slam where a person, and this is an unfortunate phrase, the call centers use this turn them and burn them 30 minutes in and out kind of a mentality. Anybody on this call that's ever done a Medicare, really good educational Medicare conversation knows you cannot do that in 30 minutes. People are confused. It could take anywhere from 1 to 2 hours and maybe in multiple conversations for people to really understand what their options are. So the SOA 48-hour rule is more geared towards preventing that type of turn them and burn them attitude. And in conjunction with that thought, you see the 12-hour cool-off after an educational event. You may have seen or heard that you can have a kind of a Medicare 101 down there at the local library or perhaps even at your own office. And that's a very effective way of getting multiple people in a room to teach them the ABCs of Medicare. Well, oftentimes when a person hears that, they may approach you after the meeting and say, hey, I think I want to get one of those Medicare supplement plans. What do we need to do? Can we take care of that? And in this case, you'll just have to say, I'm sorry, we cannot have anything to do with enrollments or appointments until at least 12 hours after this educational event. So these two bullet points here are designed to help people have proper time in order to understand their options, and more importantly, to protect them against some improper marketing, aggressive marketing techniques that will slam people into plans that'll ultimately not be in their best interest.
Mike, can I ask another clarifying question here?
Please.
So the example you just gave was someone does an educational event, then someone comes up and asks them about a Medicare supplement. If you, before you said what you said, here's what I would have said. I would have said, well, Medicare supplements aren't really regulated by CMS. They're regulated by the states. And so if it's a Medicare supplement, CMS cannot enforce a 12-hour wait period on a Medicare supplement. They could on a PDP or an MAPD. Is there in the legislation or in the regulations, are they going to be doing that for Medicare supplements and maybe hospital indemnity plans too? Or
Well, yes. In fact, if you think of just any product that's on the scope of appointment, including dental and vision and hearing and hospital indemnity, just in general, what they're trying to do is prevent aggressive marketing and getting people, in the moment, so to speak, to sign up for any type of a plan. And you're correct, MedSups are managed by the state departments of insurance. Generally, the scope of appointment rule and these educational events and banning marketing and educational events are geared more towards Medicare Advantage Part C and prescription drug plans Part D. But with regards to the Medicare Advantage plans, that's really, at the end of the day, what they're trying to do is prevent agents from doing mass enrollments. And in the past, we've seen where people will come in and they sit down, maybe 15, 20 people in a room. The agent's going to conduct a 101 for Medicare education. And next thing you know, they're signing up 5 or 10 people at a time. And that's just not really the best technique. Something will be missed. And CMS has now understood that when they look at why complaints to Medicare come in, generally speaking, that's where they happen, either through a call center or through an educational event where someone has just been slammed into a plan, feeling a bit pressured from some aggressive marketing. And unfortunately, we're painted with the same brush. So even though you may not be doing that, because somebody else that has a license is doing that, we're all kind of looked at in the same manner when it comes to CMS. So that's the impetus behind this here. And please keep the questions coming. We are asking that CMS postpone these proposed regulations until 2025 to give more time for implementation and adjustments. As you might expect, whenever CMS does something, that also puts pressure on the insurance companies where they now have to go rewrite all of their agent training guidelines. The Medicare certification courses all have to be updated. And then the compliance departments all have to get busy trying to figure out how to stay compliant. So it's a quite expensive proposition just to throw additional regulations in at the last minute.
Mike, can I ask another question here?
You're asking good questions, so keep on.
Well, this one is, I didn't get this myself, but we have agents that have called and talked with me about their conversations with some of your colleagues there. And they were told that after the 1st of September last year, CMS stopped taking calls both from NABIP, I still can't say that, and from AHIP. Is your organization being accorded what we would hope to be the proper attention by CMS, or have they sort of? I got the impression that they were almost hunkering down last year and putting their hands over their eyes and putting their hands over their ears and just not listening to people.
Wow. I will say that's a very astute observation, and I won't get too detailed here with my answer, but just to say, when I told you earlier that I've learned a lot over the last 4 years about how things work in DC, without naming names, let's just say that a consortium of people, some of which included ex-CMS employees, frankly told me that when CMS makes a decision, they're pretty much 95% baked into what they're doing. And the other 5% is just because they have to go out for public comments. But these public comments that NABIP and NAHU has extensively made every single time the bell is rung for comments, we've stood up and gave them very detailed, complete thoughts. And I believe that it's unfortunate that they have been properly ignored. And I've got proof of that. So it's not just my opinion. It's very, very frustrating. And, you know, when you take the reality that there were roughly 20,000 complaints to Medicare in 2021, or 2020 rather, excuse me, but in the year of 2021 to 2022, those complaints went from 20,000 to 40,000. To CMS, that's a problem. But when you really look and think in terms of 63 to 64 million people and only 20 to 40,000 of them complained, if you're playing baseball, that's a pretty darn good batting average, isn't it? So it's very, very frustrating. And that last bullet point I hear just put up, the one that says remove the agent from the third-party marketing organization definition. As a third-party marketing organization, those are the companies that are out there doing the call centers, that are making the commercials, the ones that have the backing of stockholders, that have millions of dollars for marketing. And now we're included as agents and brokers in that definition. And we've really struggled with CMS trying to help them understand the difference between a real TPMO and what a boots on the street broker does to advocate for their clients, including post-enrollment sales activity like answering claims or ordering ID cards or helping them pick a new PCP. Whereas, unfortunately, the people who may have been working in that call center in November and December, when it becomes January, are they even still employed at the call center? And that in itself is a huge question. And so it's very unfortunate that definition of TPMO and includes agents and brokers.
Mike, I'm sorry, can I interrupt again?
Mhm.
So a lot of the agents out here, as far as I can tell, have the impression that the definition of third-party marketing organizations was changed at the last minute on the comment period, and that was sort of illegitimate. And they are wondering what is the underlying message to say that we're third-party marketing organizations. What was the motivation of these directors at CMS to actually insert that in at the last moment? How does that benefit them? What are they trying to do? Are they trying to kill the independent channel is the question that I'm often asked.
No, they're not necessarily trying to kill it, but it's a great question and one that you and I can spend an hour to talk about once we're finished here. I'm going to answer your question, but I do want you to understand the depth of your question. And I will suggest to you that it's a very strange dichotomy of the over age 65 impression of agents with CMS versus the under age 65 ACA impression of agents, where CMS embraces agents on the under age 65 platform to the point where they even give them things like a certificate of excellence that they can put in their email signature. And they really like having agents in the ACA world. But for Medicare, CMS has always had an attitude, these are our Medicare beneficiaries, not yours and not the insurance company. Our job is to protect these Medicare beneficiaries. They're vulnerable, etc. And so when they, to your comment about, do they understand what an agent does and why would they put them into the definition? No, they don't really understand what an independent agent does. And we have tried and struggled while trying to help them understand. And now, thankfully, Senator Rounds out of South Dakota has proposed legislation that will actually remove agents and brokers from that definition of a TPMO. As a side comment, what I've learned and noticed is that, and certainly it's hard to not mix politics in, especially when you're dealing with healthcare, which almost consumes 1/5 of our gross domestic product. There's a prevailing attitude of regulation and overregulation in the current administration. I could certainly go on for a day about that, but I'll just trust that you'll understand that I'm not trying to be political. I'm trying to make a very factual statement. And the egregious overreach that we experienced with CMS adding the definition of a broker into a TPMO was, in my opinion, a very huge overstep of what their authority and scope is at CMS. And so it's unfortunate that they did not listen to us on several occasions and had basically made up their mind. And I spent probably the last 18 months of my life answering phone calls and emails, trying to defend agents or explain our position and help them understand that, unfortunately, there is an atmosphere of over-regulation in DC right now, and it's cyclical. We hope that will dissipate at some point, but as we speak, that's what we're dealing with. That is the current climate. So that said, let's look into some of this legislation. COBRA is creditable coverage, observation status, the Bennies Act, and health savings accounts. These are just some of the many things that we've been working on over the past several years. All of this is here as a reference for you. This came this morning. I did these print screenshots from the NABIP.org website. If you go there to NABIP.org and scroll down to the bottom, you'll see there's a button for Medicare resources, and you'll see some of these screenshots. But the Medicare marketing rule that we just talked about, that's explained right there in greater detail. New legislation is being filed, but Senator Rounds does not have that bill number yet, or else I would share that with you. COBRA is creditable coverage. This is crazy because you would think a person who has a group health plan and then retires and has COBRA, because let's face it, somebody might have to retire because they're sick. Let's think of somebody who might be going through cancer treatment and they're trying to use these facilities that COBRA, their health plan, has already arranged. And now you're telling me COBRA is not creditable coverage. So if somebody keeps COBRA, that would be considered a secondary payer to Medicare. And if that person experienced $150,000 worth of outpatient chemotherapy and radiation, and Medicare looks at that and says, well, you know, we don't have to pay, and the COBRA company says, well, we don't have to pay because we're secondary, then that person may be stuck with a large bill. And this is an exposure that's happened many, many times. So we're asking that language be added to the Medicare and new handbook. If you'll notice on this year's handbook, there's some references on page 18 and 88. If you don't have Medicare Part B, but you're eligible and you don't have it for at least 1 year, then you're going to have late enrollment penalties. And even if you're enrolled in COBRA, that's not recognized as creditable coverage. We're simply stating we want COBRA to be recognized as creditable coverage that is equal to or better than what's available through Medicare. And if a person wants to keep their COBRA for the up to 18 to 36 months, depending on the situation, they should be able to do so. The other side of that logic is we all know that the Medicare Trust Fund is taxed, that we have a lot of unfunded liabilities, not only with that, but also Social Security, that the Part B premiums, which are driven mostly by a contribution from the beneficiaries, is also going up and becoming more expensive. And, you know, we just don't think that it's necessary that we start putting more people into Medicare. If they've got a COBRA option, from a budget perspective, that would help Medicare to better manage the money that they do have. So interesting though, COBRA is not considered creditable coverage for Medicare Part B as in boy, but it is considered creditable coverage for Part D as in drug. Here are those references in the Medicare New Handbook on page 18. We're simply asking that they make stronger emphasis to say if you're not eligible for a special enrollment period, that you could be penalized. Another status, pardon me, another scenario we're working on is observation status. As you probably know, with COVID, the public health emergency is coming to an end, and CMS has given grace that if a person went into say emergency room and they stayed there for 2 or 3 days under observation, but they weren't admitted as an inpatient, that's been forgiven. If they needed to go into a skilled nursing facility, they were allowed in. But now they're going back to the old way, which means if you do not have at least a 3-day prior hospital stay before being admitted to a skilled nursing facility, then the skilled nursing facility will look for the beneficiary to pay the bill, not Medicare. And we feel like that's onerous as well, especially when it comes to readmissions. So we're asking that observation status waive the 3-day hospital requirement. Then there's also the Benny's Act, which is known as the Improving Access to Medicare Coverage Act. This is where a person would be allowed to have an observation stay counted towards the out-of-pocket hospital services in Part A skilled nursing facility care. There's a couple of different bipartisan bills. These bill numbers will change because these were filed in the 117th Congress. We're in the 118th Congress, but you can see that there's a consortium here of both Democrats and Republicans, both from the House and the Senate, that are supporting this. So we are getting attention of making this problem going away. But now, hey, almost 40 minutes into our presentation, we're going to have a CE check-in time. There are 4 parts to Medicare. Part A, hospital. Part B, doctor office and outpatient. Part C, Medicare Advantage. And Part D, prescription drug. My question is this true or false? And I believe Doug had explained that you should just type in your answer. Is it true or false? And the answer is true. These are the 4 pillars of Medicare. And if you can just get people to understand these parts, then also plans, parts and plans, some basic terms, and you'll be successful in this business. Doug, any comment here? Anybody having any technology challenges?
I do. Where's my chat?
It's in the lower right-hand corner. It's it looks like a page with lines on it.
I got it. Okay, thank you.
You bet.
Okay, I will continue on here. We need to pick it up a little better. We'll never get through this, and it's partly my fault because I don't want to stop these questions. But I also want to let you know that there's a lot of information. We'll never cover it all in one day. We did get successfully. We had passed the Benny's Act, and that was successful a few years ago, actually. And this basically softens the lines of when people can enroll. Some goofy rules existed about if you turned 65 in April, but you didn't enroll in Part B until May, that you would be postponed for an additional month. And it never really made sense why they did that. So we got that cleaned up. And then we also allowed for more exceptional circumstance SEPs. Like, for example, let's say y'all get 20 inches of snow today and people get locked down and they can't do anything for their April 1st effective date. They may be granted a weather SEP, special enrollment period. So that has happened many times recently with tornadoes, hurricanes, fires. So that said, just know that was part of the Benny's Act, is to give people more grace, because not everybody can just jump online and do something right now. They may not have access to high-speed internet, and they may be out in a rural part of Utah, for example. So getting access to them face-to-face isn't always easy. For those of you that are in the group health business, you may have bumped into this before, where if a person turns 65 and they enroll in any part of Medicare, including premium-free Part A, they are no longer allowed to contribute to their health savings account. And to me, this is just, simply put, it's age discrimination. I bet everybody on this phone call knows many people who are continuing to work past age 65, and some of them may have a high deductible health plan and want to contribute to their health savings account. And we're just simply saying, if they want to enroll in premium-free Part A, then let them, and allow them to continue to contribute toward their HSAs. Or even if they want both A and B, but they keep their high deductible health plan in force, they should be allowed to contribute. The Inflation Reduction Act, you all may have heard about this. Looks like I've got a typo on my screen there. It says September 2023. Sorry, it was passed in September 2022. The Inflation Reduction Act, starting in the year 2024, will allow Medicare to negotiate with pharmaceutical companies on drug prices. Now, the IRA, Inflation Reduction Act, has many, many other things that it did. Understand that I'm just pulling out the parts that reflect Medicare topics. Drug makers will likely offset some of their reduced revenue from Medicare negotiations with higher prices from patients with private insurance. And I don't have to tell you all, you pretty much can understand when I say big pharma is going to get their money, you know what I mean. So if they take that air and squeeze it from one side of the balloon, it's not going out of the balloon. It'll just be on the other side of that balloon. So you can expect a little cost shifting to go on. Just keep your eye on that. 2024, the Department of Health and Human Services Secretary is to begin phasing in price negotiations for some high-price single-source drugs. And to make that work, the HHS Secretary is supposed to choose 10 negotiation-eligible drugs for 2026 and publish their names by the selected drug publication date. And these drugs will be chosen from among the 50 medicines responsible for the highest Medicare spending that have no cheaper generic or biosimilar alternative. And the first group of medicines would be most likely include those sold mostly in pharmacies to treat diseases like diabetes, cancer, and arthritis. So we're about to see the government start negotiating drug prices, and this should be some pretty good political theater, if you know what I mean. And starting just this last January, standalone Medicare Part D or Medicare Advantage plans that provide drug benefits must limit the patient's copayment for certain insulins to no more than $35. And this has caused a little heartburn, because of claims issues. Some of the companies are still getting kind of used to this. And of course, not all of the insulins are covered. So some people think, oh, well, I take this insulin that costs $600 a month and it should be $35. And that is simply not the case. Some of the insulins will be priced up to $35. So you're going to have to get good about taking notes and making sure you've got the right insulin covered by the formulary before you enroll someone.
Hey, Mike, this is Bob. Is
Yes.
there any place where a agent or a beneficiary can download the list of the $35 drugs?
No, but I participate in a group that's called the Advanced Medicare Advisors, and it's just a group of people that we've known for years that got together from coast to coast, and we have monthly calls. And there's an unofficial list that we've compiled that will be kind of a helpful tool. I'll be glad to share that with you. If you'll just shoot me an email, I'll send it to you. My email is mike@thebrokerageinc.com. And I'll repeat that later on too. But there's not an official list. And it's really tricky because it's almost like you have to go online and quote these drugs with and without the insulin, just in case the company changes their formulary and now all of a sudden that insulin's not covered, then you're going to have an upset customer. So that said, beginning in 2026, that limit will change to the lesser of $35 or 25% of a specified maximum fair price or 25% of the negotiated insulin price. So the idea here is to try to make insulin more affordable. That's the impetus behind this part of the Reduction Act. Also, the IRA changes some of the max out-of-pocket on spending. In 2024, there'll be a transition year capped by a catastrophic limit of only $7,050. And then in 2025, PDP and MAPD plans will limit their enrollees' cost sharing for covered prescription drugs to $2,000 a year. And in this last year, that would have impacted about 1.5 million people. And I will tell you, from having run way more drug plans than I ever care to brag about, that when people go into the gap or donut hole, they usually blow past it and get into the catastrophic phase. And this is going to be a good thing for a lot of people. But let's talk about reality. You're putting handcuffs on the insurance companies where they're allowed to charge more than $2,000 now. When that happens, what do you think is going to happen to the premium? But here's the problem. The Part D drug plan premiums are capped at a 6% annual rate increase beginning in year 2024 through 2029. So now I want you to put your thinking cap on. Let's pretend that we're all a part of the company board of directors and that we have one of the popular drug plans that are out there that insures millions of Americans. And now the government is telling us that we can't increase our premiums, but we're going to have to cap our out-of-pocket at $2,000. And if you know the drug plan benefits well enough, you understand that's a razor-thin profit margin at the insurance company. So you might expect that a lot of boards of directors may be sitting around scratching their heads about whether or not they even want to be in this business next year. So I expect that going into 2024, we're going to see a lot of changes in Part D. Here's a time frame for you to consider. Again, you can have these slides, so I won't go through all this, but that's basically explaining how this is going to work. And then this new thing that just starts tomorrow, April 1st, is the reduced coinsurance for certain Part B rebatable drugs. So I want you to not get into the weeds on this, but just to understand, the good news is the government's trying to do something to put the squeeze on big pharma and follow through in that what they promised in the form of lower drug prices. But we all know the devil's in the details. So just kind of keep your finger on that pulse as it develops. There's also a new Medicare disclaimer that you're required to read that says you do not offer every plan in your area. And if not, then they are to contact Medicare.gov. Some of those new proposed regulations are going to expand on this disclaimer. Our recommendation is that the disclaimer not have to be read, but be provided in writing, whether that's through email or some form of a disclosure, like we have buyer's guides and things like that that we have to provide for various products, whether they're annuities or med subs, to try to streamline a lot of this stuff. And that disclaimer also has to be put in all of your marketing, your website, print materials, your email signature, even television commercials. You've probably seen some of that. Has to be conveyed verbally, electronically, or written. And if the TPMO is providing the information to the customer verbally, the disclaimer must be stated within the first minute of the call. Call recordings also. All recordings for Part C and D products. So I think, Doug, you had a comment about MedSup earlier. MedSups are not included in call recordings. That requirement is for virtual and telephonic engagements. Face-to-face beneficiary engagements are not required to be called or recorded, and MedSups don't need to be recorded. Zoom calls are to be recorded, and if a person opts out and doesn't want to be recorded, then what do? You have to have them come see you face-to-face. If they don't want to do that, you can't help them. So you see now how these egregious regulations, as I described earlier, are a bit of an overstep into a reality that CMS does not understand. All right, CE check-in time. Agents will be required to record phone calls that may result in an enrollment effective October 1st, 2022 for all Part C and D products. Is that true or false? It's true. So if you please make your note in your, so we can record your attendance. And then I'm going to wrap up really quick here because I know we're up against time, just to kind of share with you some things about what NABIP's doing to support agents. And there's a certification class. You can go online, you can take this Medicare certification class. You can go to the NABIP website and see all the different companies that accept the certification class. It's $100 and it comes with up to 8 hours of CE. Ideas that you can use to either grow your own chapter, or if it's a case of a private business, here's some things that you might consider. Set up a study group. Have this kind of a conversation that we're having here, like you all do in your Pinnacle series, which I think is awesome. Or you could also host a Medicare summit, and we've got a blueprint to help your chapter put things like this together where you can get carriers to support it. This is a great way to not only get your chapter up and running or grow, you could also use this as a recruiting tool for your agency. We also have a full-blown Medicare portal, all the various things here that you see on the screen, like the Medicare marketing rules that we talked about. All these resources are here for your convenience. The Medicare certification that I just mentioned is all there. And just as you'll note in that yellow toolbar at the top, we need to get Aetna on board. So if any of you have a relationship with Aetna, you need to get in their ear and tell them they need to add the NABIP Medicare certification right now. We also have different types of resources that you can use to help explain the concepts of Medicare. We also have a B2B format where you can enroll yourself, post a question if you need an answer. Maybe it's a question about insulin or that Part B rebate we just talked about. And all these other, there's about 500 professionals in this community, and they'll send answers, and we'll have very good debates about things because not everybody agrees with whatever they've interpreted. There's a way that you can sign up here. I've given you the hyperlink. And now I'm going to have another CE check-in here for you. Can a Medicare beneficiary use a health saving account fund to pay for certain Medicare expenses, including Part B premiums, Part D premiums, and Medicare Advantage plan premiums, or any types of co-pays, deductibles, or coinsurance? Health savings accounts. And the answer to that is yes. If you'll just type that in, I gave you the answer. Now let me throw you a curveball. Can an HSA fund be used to pay for a Medicare supplement plan? And the answer to that is no. Going back to the resources, we've put up here all these 2022, that is, marketing final rules, and mentioned also there's new proposed rules for 2023. So again, we can go through that today because that would be about a 2-hour overview. But just to know that you've got resources, I want you to have good takeaways. We also do a quarterly newsletter that hits on a lot of the top things that are developing in the world of Medicare. And then scrolling down that page, you see all these different things like the FMO Council. As I mentioned, I'm chairman of the Medicare Advisory Group. But there are different FMOs you may have heard from in the past, some of which you probably work with. And this is a great group of about 13 different national FMOs. And we get together a couple of times a year and we talk a lot to each other, about distribution problems or how to recruit or where not to go to get leads, and just in general kind of look out for each other and make sure that we have a healthy distribution channel for independent agents in the United States. And then I believe this might be our last CE check-in. Observation is a reference to a hospital service where people may go to seek SHIP counselors' advice on Medicare Advantage plans or Medicare plans. It's a outpatient doctor office visit to observe COVID symptoms, or is observation a period spent in a hospital when a provider is deciding whether to admit a patient as an inpatient or release them to discharge them. What is observation? And if you don't mind, just type in your answer in that chat box. And of course, you should know the answer is also C. All right. Like I said, the Medicare Advisory Group, that's where me and our 16 comrades there get together each month and talk about issues and regulations and try to shape the industry and keep it healthy and vibrant. There's Medicare summits that you can host. All of the information I mentioned, that blueprint, the Medicare Summit in a box. There's also brochures that you can download and order. So sometimes people don't want to use a carrier publication. They don't want to be known as the Aetna person or the Humana person. They want something generic, and they don't want to use the Medicare publications that come from the government. So here's a private market solution for you to help explain Medicare. And then we also have recently developed these flyers, which you can also customize to help you better explain things like what is a Medigap plan or a Medicare supplement plan? How does that differ from a Medicare Advantage plan? Or if you just need to put something down initially to get the ABCDs out of the way, start that conversation and let them know that you're a resource for this type of stuff. Or maybe you're in the group benefits business and you know somebody who's approaching 65 and they're not sure if they should take Medicare or keep on their group health plan, or maybe they should enroll only in Part A. And what do those questions look like? And this brochure helps you to get this flyer helps you to get those questions on the table. And if you scroll down this page, each one of those different flyers, you'll see where you can add your name, phone number, email. Or if you just want to talk about the difference between a traditional Medicare option versus a Medicare Advantage option. I personally use this one. If somebody calls me to say, hey, I'm trying to figure this out, I send them this flyer to get that conversation going, and that ABCD flyer, and it really does a good job of setting the stage before I talk to the person. So we're up against the hour, and I know that we're a little past, in fact, but I will be here for another, 10, 20 minutes if you need me. And if you don't have a comment or a question, that's okay too. You're welcome to reach out to me and share your insight. If there's something that I can do to help you, I will. I'm not necessarily trying to generate business or recruit you, because really that's not the intent. I want to help you. That's the intent. And I want your feedback too, so that we can continue to bring good ideas through the private private market so that we don't have more egregious, onerous regulations and legislation put upon us. So I will turn it back to you all for comments.
So, Mike, I'm going to, I appreciate the offer for staying on because I know that several people are expressing questions and raising their hands. So let me thank you for what you've done. Josh, thanks so much for setting this up. We have recorded this. We are going to be posting it. I know that I intend to listen to it 2 or 3 times to try to pull stuff out of it that I know that I wasn't catching the first time. We're going to post it on a site called Medicare Plan Details. You just have to have a password to get into it. So we're trying to have it so only agents get into it. So it's called, the password is lowercase MA 2023. So Medicare Plan Details, and the recording will be out there so that you can look at it several times because there is quite a bit of information. And if any of you do have questions now, like Sharu, please turn on your mic and ask Mike the question that you have.
Oh, I don't think I have a questions. Did I say I have a question, Dan? I thought this was
Yeah,
your
well,
husband.
that's what raising your hand means, is that you want to say something.
Oh, okay. I think that's accidentally I raised my hand. Sorry about that. How can I take? Okay, I took that off.
Mike, if you'll put your question into the text, I can relay it to Mike.
This is Nancy Kuhn. You said you didn't want to recruit us, but what if we want to know how to be recruited? What can your organization do for us as agents, and how would we join? I mean, obviously you're doing the legislative piece, but what else?
Are you talking about joining NABIP?
Yes.
Josh, you want to take that?
Thanks for the question, Nancy. So on the NABIP.org site, or if you went to wahoo.org, but I think you can go right to NABIP.org. There's going to be a link to register. There's probably a whole nother hour. Matter of fact, I do have a presentation that's an hour long that goes over all the ins and outs of the association. But let me tell you, one of the things that's a little different than Medicare that we did this year, and you guys may be familiar with the prescription couponing bill that was trying to be pushed through the legislation. And we spend a lot of money on a lobbyist. So the Utah chapter does. We've got a lot of money invested in a lobbyist who we also use to battle against that. And if you paid attention to that, almost every insurance agent should have been up on the Hill with that. For example, I had an opportunity to testify against that bill. That was one that was going to increase medical premiums at minimum $10 per member per month. So for my family of 5, that was $50 more a month. Part of that legislation was beneficial to consumers, but we're most often against mandates when it doesn't benefit the majority. And we were able to put that bill on hold so that we can come back and reevaluate better ways to do that than things that are going to increase the premium. So as a lobby organization, we do a lot of that locally and then nationally. The CE that Mike just did, this is something that's a benefit of the association. The monthly things that we do would be on top of something that Stonehill does. There are leadership trainings or modules that you can go online as a member. You can learn about public speaking, how to sell. There's just a plethora of different opportunities there, many of which are no cost. And then there are other items that are cost. So one of the events trainings that I took a couple of years back was on self-funding. And I got a certification for the self-funding course. And just as Mike had alluded to, there's one for Medicare as well. So trainings, and then being able to be face-to-face with local agents here, and kind of a pile of them. I think we've seen a lot of those today. And then Mike showed a number of screenshots that give you access to things that are online. But I'm curious, Nancy, was there something that you saw specifically that you liked?
Well, I just like supporting the organizations that are fighting the legislative piece. I want nothing to do with that, but I'll throw money at people who will fight that for me. So, what's the cost?
Well, that's a good question, Nancy. I want to say the cost is probably just over $400
A year. Okay.
a year. Yeah.
Great. Thank you so much.
You're welcome. Thank you for asking.
what can we do as agents? Or, I mean, I get so frustrated with the abject stupidity of the SOA and all these additional ridiculous requirements they're coming up with. What can be done to stop the stupidity? I mean, these numbskulls, these idiots that have zero clue about life or about business or about people or about insurance or about anything are just dictating every word I can say and everything I can do, and it's interfering with how I can serve and help my clients. It's hurting the people they pretend that they're helping. What can we do to undercut that or stop that or change some of that stupidity?
Josh, I'll jump in on that one real quick and just say, reaching out to your local rep, both state and federal reps, federal, obviously House and Senate, because it's more of a federal issue when we talk about Medicare, and expressing the concern that you just had. As a citizen of this country, you deserve that privilege to talk with them. And they are very responsive, by the way. A lot of them are staffers that you're going to talk to, but they don't really understand the problem. Pardon me. Let me explain. I went to my own rep in DC. Josh mentioned we were there for some lobbying recently. And this young lady grew up in my neighborhood. I didn't know her, but when I started telling her about this, she said, wait a minute, my parents both just got licensed. And I said, well, do they know that they have to record phone calls? And she goes, are you kidding me? She just kind of rolled her eyes at me. And she said, I tell you, this administration, and that was basically saying, I'm so sick of this. It's a known fact that the overregulations are happening on purpose in DC. And again, you need to get political here, but the only way that you can fight this is to make your voice heard. Second part of that answer, and then I'll shut up, is that there's what's known as an Operation Shout, and NABIP sends these out. The Operation Shout is a prepared message that you just simply add your name to if you agree with it. And if you want to change some of the wording, you may also do that. You can just sign your name and it'll automatically send it to your rep or your congressperson. So getting your voice heard is the best answer I can give you.
Thank you.
So, Mike, let me add to that a little bit, because we spent a lot of time talking to Mitt Romney's office, Mike Lee's office, Curtis's office, and a number of them up there. One thing, they don't know the issues that you're running into. When they hear this stuff, this legislation being passed, they just assume in many instances that everybody's okay with it, because this stuff isn't, it's just affecting Medicare. But when they hear from you the problems you're running into, such as, I can't have a professional conversation with my client because I've got to wait X number of hours, they've got to sign this, I have to give this disclaimer. When you present to them in a very short story of why you're not able to be as professional to your clients, this is one of the examples that we use there, they need to hear that. And then when this legislation comes up, for example, there isn't anything legislative up there right now. So they want bill numbers. That we don't have any of that. But if you drip them, here's the issue that I'm running into, and then you're building some rapport with them ahead of time. And then by the time that bill does come up, you can say, this is the bill I was talking about, and this is the one that I would have you vote for or against. But they don't get a picture painted with the legislation that gets passed. They only know how that's affecting people if you reach out to them and share that with them. But you got to be short and to the point for them to understand that.
Thank you.
Actually, this is Sharu. I do have a question about the SOA, the 48 hours before. Does it mean we cannot meet with the client before the 48 hours the SOA sent out?
It's proposed. It has yet to pass. I expect it will go through, and I expect people will ignore it. But as we speak, you can go ahead right now, but this proposed 48-hour rule will probably be implemented sometime between now and the next annual enrollment period.
Okay, sorry. Got a phone coming in. Could you please repeat that again? So,
The 48-hour rule is a proposed rule that will probably be impacting your next annual enrollment period. But right now it is a proposed rule. So you can still take an SOA at the point if somebody walks in or calls you.
Okay, got it. Thank you.
Welcome.
Well, Doug, thanks for having us here. This has been great. It was helpful for me as well. I haven't heard some of the updated information that Mike had to present today, but Stonehill, we want to thank you for inviting us onto your show this morning.
Well, thank you again so much. And again, I just want to remind everybody that if you want to hear this again, we are going to post it on MedicarePlanDetails.com. It's very simple to get to. And if you have a question, give us a call. And we'll see you all next time. Thank you again.